Oh, well, good morning, good afternoon, good evening, everybody, depending on where in the world you are. Welcome back or welcome to our ongoing lecture series regarding state of child health based on the globe, and thinking about career paths and great work that's being done to advance health equity in really many different settings and sessions. I'm Sohail Sood, one of the faculty members at UCSF, co-directing this series with the amazing Dr. Teresa Kortz. This morning, we're welcome to join Yousef Turshani to the series. Longtime presenter, and he'll be going through his career path. So I don't want to do too much of an introduction to him because that's the entire talk, or the majority of it. I will just say he's a man who's worn many different hats over the course of his career. Having worked in refugee and humanitarian settings, having worked in an island medicine setting, having worked in clinics, in primary care clinics, having worked in inpatient settings, and not only having done a lot of that work, but having led a lot of efforts and often assuming leadership positions along the path. I think he'll talk a little bit about his family life as well. A great chance to hear about many different ways your career can move forward. And with that, I will turn it over to Yousef to go from there. But thanks so much for joining us.
All right, great. And nice to see familiar faces and the new faces that are here too. So we have until 11:30, so 55 minutes total. And my goal is to stop my talk about 10 minutes before the end to allow for questions. I'm sure some will come up. And just to get the juices flowing, if we can spend a couple minutes, if at least the 5 residents, if they are on, who are on the track, if you can share a little bit about when you think about what you'd like to hear about someone's journey. And I will start the journey when I'm in your shoes as a resident and go through the next 12 years of life. There's one thing you'd like to hear. Please unmute yourself. It's camera if possible, but I understand if not, and let me know what you'd like to know. And since you maybe know the names, Teresa or Sohail, I'm going to call them one at a time, or
I was just going to offer to do that.
Okay.
Go ahead, Sunny.
I can go first. Hi, I'm Sunny. I'm a peds intern. Maybe because I'm like early in my career, like I don't know how I'm gonna like incorporate my love for medicine into global health. But I would love to hear more about like how you find the locations to work or the programs that you ended up, and like what are some like lessons that you've learned to get to that point. Because I think I'm personally interested in like direct patient care. I really appreciate like one-on-one interactions with patients, like on the ground. So like I think that's something that I would love to hear from you.
Excellent. I'll definitely be able to do that. The short version is have friends who have good blogs that you follow. Chris, go ahead. Next person.
Ted, do you want to go?
Sure. I'm Ted. I'm a pediatric intern. I guess my interests in global health are pretty similar to Sunny as well. I like to learn more about kind of the practicing in that kind of setting, and kind of how you've had to, I guess, learn how to practice in that kind of environment.
Great. Definitely we'll cover that for sure.
And then Matt.
Hi, I'm Matt. I'm one of the Pete's R2s. I've actually met you before once on one overnight shift that we've had together. So I have a preview of this. So since I sort of know part of your talk, if you could go a little bit more into the practical situations with how did you figure out things with your partner in terms of moving to different places and career trajectories, and how that might have shaped both of your careers?
Yeah.
That was
again,
great foreshadowing. by the
yes,
way.
that was really good. And again, depending on Q&A and how that goes, I will invite my colleague Chris to also share his journey, as he also did a lot of his work with his partner. Is that the residents that we have for now?
Yeah, and I
Okay.
just wanted to open up and see if there's anyone else who had
Yeah.
a specific question or
Yeah.
would like to hear about anything, and then.
Mm-hmm.
Okay, and I can watch the chat for you as well.
Perfect, thank you. So I will begin sharing my screen. So 1 second, let me be able to adjust the size so I can see my notes as well, and I share the right one. Okay. And I'll let you know. So sharing should start now. Okay. So does everyone see my title screen here? All right. So the kickoff slide here, I will talk a bit about, it'll be 2 different talks. It'll be my 2 major global health pieces that I did. So this one, as well as my time in Saipan. The reason I think this slide starts off with a great title is that motto of Doctors Without Borders, or Médecins Sans Frontières, is really the way I try to envision my life, is put my ideals into practice. And I do also use this opportunity to say this is the life of a individual person who did this type of work. Everyone's journey is going to be different. And I think just showcasing one particular person's journey is maybe helpful. My roles, so I have remained connected to UCSF ever since I finished residency. I finished the same year as my colleague here, Chris, when he finished his chief year in 2009. And initially, I'll talk a little bit about what I chose to do, but I stayed on as a volunteer faculty and have remained in that role throughout. And my current role is I am about half hour south of you all, if you're in the city right now, in the county of San Mateo, in the city of San Mateo, where I'm now the chief medical officer. And I'll talk about how I got there. So the 2 talks that you would see if you rotate with me at the general, and Matt was fortunate to be on rotation with me recently. And so he either saw my talk about Doctors Without Borders when I go into that a bit more, or the work that I did in Saipan when I lived there for some time. I like this slide because it does preview, I think, a bit about what I feel about the journey, is that there's a mix of tranquility and things that put you at peace, and then those are warships off on the horizon. There's also a mix of foreboding and uncertainty that will always be part of the journey. And that's this ever-changing reality and adjusting to what's in front of you and using what you've done and where you want to go to be able to decide the journey for yourself and what's next. So what I will do is go over my particular model, and that's why I say a model for choosing your own global health path. I kind of jokingly call my first 3 years my 3-year quote fellowship. I had 3 jobs in 3 years that were all very different, and each year I gained a different skill set, worldview, different pay rates. The shifting tides of life and how you decide, just as this picture alludes to, it's an ocean. The tides will rise, tides will fall. You'll have different things that are really important to you in your life and how you decide that. Depending on our time, I may go over the cases a little bit, but again, that'll be a preview for if you're on a night shift with me, we'll actually spend a little bit more time on the clinical cases. And then again, Q&A. So I will ask someone who's keeping time, maybe to let me know when we are 15 minutes from the end, so 11:15. So I'll be able to keep track. Can I ask someone to say that they will do that, just to confirm?
I can do it.
Thanks, Tiffany. So one model I've been able to put together from lots of conversations and pulling in different things is trying to think about, in the same way, if you'd pick any particular subspecialty, how you would decide which subspecialty you'd want to go into. And so, for example, if we pick GI, the skills you'd want to gain both as a resident and then as a fellow, you'd want to know how to do endoscopy, for example. You'd want to be able to know how to manage both the newborn and the teens and the different ways that you'd have to manage those type of patients. You'd want to be able to think about what organizations do you want to work in. Do you want to work in an academic setting, a multi-specialty GI group, or something else? Are you interested in the leadership role? Do you want to be the director of, endoscopy, for example, or liver transplant? And in that same way, I would think in global health would be, for example, procedures. If you know you're going to be doing clinical work abroad, you will likely not have any subspecialists around, potentially within the same time zone or the same continent, and be able to be comfortable for yourself. And so what are the things that is important to you? Being really comfortable with NRP, being comfortable with intubations, being comfortable with whatever procedures you think you might want to do, and gain those skill sets. And if you don't gain it in residency, look for a job that's right out of residency that you would gain the skills that you want. Leadership, being able to feel comfortable overseeing not just other physicians, but potentially NPs, PAs, other affiliated health workers, and feeling comfortable as an R3 as you're leading your team. What does that feel like for you? Does that feel like something you're interested in? What type of organizations you want to work with? A very large, well-established international organization, or directly partner with a small clinic or small hospital in a rural part of a country that you know nothing about, and answer those questions for yourself. I think the skills part marries the lifestyle piece, and that starts getting into the piece of the journey. What income do you feel you need right out? Are you a person who is really anxious about having loans and doesn't feel like they can do this right out of training? Do you need to find a place where you can get National Health Service Corps and get repayment for you? Or are you comfortable deferring for a few years and really delving into this period of time, just like if someone would do a fellowship or other things where you would defer getting your full salary for later? What weather? Are you a person who can handle really hot, sticky weather? And just know yourself, to be honest to yourself. You have those ideals of the places you want to work in, but can you handle that? Or can you handle monsoons and tropical storms if you're in places that have that? What cultures do you want to be a part of? What cultures do you want to embed yourself in, or you're interested in? How does it feel to be in a place where you do not speak the dominant language, and to be mentally in that space for months, if not years? And then the big piece is family. Do you yourself have a partner? Make those decisions together about how you decide what's important for you. And the link between these two, I would say a term, and I'm happy to hear others iterations of this, is be what I call a strategic opportunist. So that's remaining focused on your long-term objectives of what you want to accomplish, but staying flexible enough to solve, the day-to-day problems and what the next step is going to be. Each individual step of your journey is not going to accomplish everything you need. It's not going to fit all your needs for either the skills or your lifestyle. But for right now, does it feel right for you? Does it feel right for you and your partner, right for you and your whole family? And stay open to opportunities as they come up. So one of the questions that came up is, how do you find out about them? I stayed in touch with people who I knew were doing global health. And back when blogs were a thing, my colleague here, Chris Carpenter, was keeping a blog of his journeys and where he was around the world. And we'll preview it a little bit, but he was in the island of Saipan for some period of time. And as I was finishing up my work with Doctors Without Borders in Zimbabwe, I reached out to him and asked, what was the experience like there? What's been going on? And do they have lawyer jobs? And I don't know if he remembers this, but I think he said, yeah, they have a shit ton of lawyers here for some reason. And so it worked out perfectly because my wife is a human rights lawyer, and we wanted to find a place where both of us could find jobs together. So that worked out. I was like, okay, I will send in my application, and sight unseen, let's try it out for a few months as a locum. And then that turned into 2.5 years of my life. Another framework or mindset that I think has been helpful that I actually learned in Saipan. So as the name sounds like, Saipan and Japan sound alike for a reason. It was a Japanese colony for a while, and there was some Japanese colleagues and folks that I knew, not necessarily in the hospital, but around. And there's this phrase called ikigai. And ikigai comes from, iki means life, and gai means value or worth. And trying to, as much as you can, constantly shift and move toward that sweet spot in the middle. How many of those different pieces are you able to be able to check off at the same time? At some point you might be doing, I would say the pieces that I was in at the beginning. Does my mouse show up here as I'm moving around? Okay. Yes. I would say my very first job right out of residency, and I will get to it in a bit, I was a neonatal hospitalist. So that was something that I could get paid for. And it was something that I did both love to some degree, and I knew that was a need that was there. And then once I was able to do that and basically get married, pay off the cost of the wedding a little bit and put a small dent in the loans. Then I did what I really love. I did Doctors Without Borders and was able to do something that I really love. And that was clearly something that there was a lot of need for. And then moving to Saipan, again, I could get paid for that. And I had the skill set. So I was starting to be good at what I did. And as I spent more time there, I realized that was something they had need for me there. And I started really loving it. So that came to a place where it came close to that. And then part of our journey coming back to the US, it was starting to move back toward what my family really needed and what my family needed and what they really loved, and for us together to find that space of how do we fit all those things together. So a nice framework to be able to have to think through it. So a little bit about my journey. Now I'm going to start dating myself. There's this book series that was out in the 80s and 90s called Choose Your Own Adventure. And one example would be like you're running through a jungle and there's bandits chasing you. Turn to page 5 if you jump off the cliff into the ocean. Turn to page 10 if you turn back and fight, or turn to page 12 if you try to hide or find an escape route. And I felt like coming out of residency when there weren't many global health fellowships around, there weren't many people that were in our circle who had done actual clinical medicine abroad. There are a lot of people who did research abroad around as a model. We kind of had to pick for ourselves what felt like the right thing to do. And I loved residency. This was back in Parnassus doing some evening rounds with my intern. He had me pull him around. He's now a hem-onc physician at Northwestern. And I loved everything I did in residency. I loved all the different subspecialties. I loved all the different places I got to rotate through. And I had the extra level of doing even more hospitals. I actually did my first half of residency at UCLA. I was in their plus equivalent at the time, the community health and advocacy track, and transferred up here halfway through. But one of the things I knew I wanted to get a little bit more confident with before I went abroad was neonatal resuscitation skills. That's one of the pictures I actually don't have in here. I was a NICU hospitalist, so we covered 3 hospitals: a level 1, Seton and Daly City, which no longer does deliveries; a level 2, Mills Peninsula, which means they can take small newborns, but they don't have any surgical care there. They don't have the jet or any of the oscillators; and then a level 3, the CPMC hospital. And there I had different levels of coverage. So level 1 and 2, the neonatologist either never came or rarely came. And the level 3, the neonatologist was there during the day, but at night we were on our own. And my colleague who's here, I was pulling, I got to see him throughout it. And he was like, it's sort of like a fellow plus, like you get all the support as a fellow, but that plus is like that other extra 100,000 of the salary. It's like, yeah, just kind of a nice way to gain those skills. So about a year into it, I felt more competent, more comfortable handling really sick babies, up to 40 babies at once at night. And I was on my own. Sometimes a 25-weeker would start delivering before the neonatologist could get there. And with that, I felt like I was ready to go abroad. So I wanted to work with a really well-established organization at the beginning, and ended up with Doctors Without Borders. And I will note here that all these pictures that I have here, there were consent to be photographed. I want to be thoughtful about the exploitive nature sometimes of photography abroad. And this was a professional organization that came actually doing fundraising, not only for Doctors Without Borders, but this local hospital that I was in. So I worked in Zimbabwe, and it was clinically probably the most rewarding year of my life, getting to care directly for patients and really removing all the glut of the American healthcare system. There's no billing, there's no extra documentation just to make things happen. This little notebook here, that is the medical record. You write only what actually matters and what's essential. This here is our formulary, just what the first line and second line treatment of antiretroviral treatment was. And just off the table here is our phlebotomy. We drew the blood right there if we needed to. And the next room over was the pharmacy where they got their medications. There's no appointments. Right outside the door, there's a bench that goes about 20 feet and people just show up. Whoever shows up first in the morning gets seen first. Second patient gets seen second. So something was really beautiful for me about that, and I love my time there. I'll do a small bit about the history of Doctors Without Borders, but knowing with time, I probably won't get to all of it. The history of it, was founded just over 50 years ago during what was called the Biafra crisis. So in Nigeria, northern Nigeria, there was a separatist group who were an opposition party to those in power in Lagos. So Lagos is in the south, right by the ocean, and where most of the wealth is in the country. And they were trying to fight for their rights and get more resources. And as a result, the main government cut off supplies to that region and was slowly starving them to death. And there was a group of physicians or French physicians from the International Committee of the Red Cross who were coming there and offering service to these families, and really felt that the atrocity of what they were seeing, the world didn't know about, because this is in the days before the internet. And one of the challenges with their work was ICRC, International Committee of the Red Cross. To work with them, you have to sign an oath of silence. So what that oath of silence means is you cannot speak or publish about anything you saw while you're in the field. And for them, the reason they did that is to reassure governments and despotic governments that we are just there to take care of the people. We are not going to speak out about it. And what they believed is it allowed them to access places and just do the humanitarian work that others may not have been able to. One little clinical piece, you'll see the kids all have their names on their forehead. And part of that is with severe malnutrition, skin integrity breaks down. So being able to have a wristband around their wrist would actually potentially slough their skin and cause damage. And so putting it in a place where there isn't much skin movement is one of these really sad situations to be able to see here. So they came back and these physicians felt like, you know what, it was so outrageous what they saw and the world needs to know about it. But knowing that if they broke the silence, that potentially they could lose their medical license. That part of one of the consequences would be that they would actually be brought to the licensing board. And for them, they felt no particular country's licensing, no particular jurisdiction was above the principles of humanitarian work for others, and that they didn't respect that there's a border, that there's a country, and hence the name. They launched themselves as Doctors Without Borders. And sure enough, ICRC did attempt to have their licenses revoked, and it went to court. And in the end, there was enough popular press that came behind them that they were able to keep their licenses and started this organization. 50 years later, and continuing to work in the most remote places in the world and places where there aren't many resources. So the three major principles of MSF, Médecins Sans Frontières, are neutrality, impartiality, and independence. And I'll just briefly touch on those pieces here. Independence, it really comes from having your own funds, not being reliant on any particular government. And so this example in Pakistan, when MSF was going to start working in the Northwest region, which is kind of the most rural and least resourced, Pakistan was asking for orthopedic support for complex war injuries for the men and soldiers who were fighting either in Afghanistan or fighting other places. When MSF did their own independent survey, they actually found that maternal child health was where the most needs were, that there was a really high rate of infant mortality and the maternal outcomes were really poor. And so they went to the government and said, I understand that's what you think you need, but we did a survey and this is what we actually want to do if you want us here. To kind of have the audacity and the gall to come to a major government and say that's what you need and what you want to do only can come from being independent. And sure enough, that's what they're setting up here is the maternal and infant units. And later on, they did eventually support them with the orthopedic care as well. And again, tying that back to the way you can do that is be financially independent. So 96% of their funds come from those mailers that you get or those calls or ads you get of $10, $20, et cetera, and allowing that to be what guides what they do. And the small amount of government funding they do get are going to be from places like Switzerland or NATO or other large organizations where it doesn't clearly tie them to one particular political view. So for me, I was actually reluctant about joining MSF. When I learned about them, one of the things I understood is when they show up in places, so Haiti is one good example, and Chris could probably illuminate more about that. When they set up emergency programs and large scale programs, it takes away the resources from the local primary care infrastructure and the local weak infrastructure that does exist, and those basically collapse. And so when they leave, they've left it off even worse than it was from before. And so a lot of criticism that come from the development world is that MSF does, they're really good at focusing on the emergency care, showing up first and being able to set up things, but really don't play well with others, don't play well in the pool, and don't care about long-term outcomes of patients. And it also was a criticism that they have all this knowledge and data about how to care in emergency settings with minimal resources, and they don't publish it, they don't share it necessarily. This all changed in the early 2000s, and this particular study came out right as I was finishing residency that really actually changed the path for me and how I thought about them. One of the main criticisms of doing antiretroviral care, basically is global prejudice was, those people in poor countries, they can't take medications long term. They don't know how to do that. They don't have the infrastructure for something like antiretrovirals. And so MSF did a massive study through Epicentre, that's their epidemiological center in Paris, that was covering something like 10 countries, and specifically ones that they thought would be the hardest to care for, little children, so newborns up to age 5, and followed them for 3 years if they actually got antiretrovirals that they paid for. And the survival rate at 1 year was 93%, at 2 years was 92%, and 3 years was 90% survival. And these are kids who are coming in at stage 4, so full-blown AIDS many times, and remaining in care connected to their primary site. At 3 years, 75% of them were still connected to care at their primary site. And one thing I kind of reflect on and joke with the residents is, if your patients you have in your panel, either at the general or wherever else, as an intern, if you have 75% of those patients as an R3, you're doing something amazing, because our patients turn over even with us, with places that have resources. And this actually changed the game. This particular article helped really push forward the Global Fund for AIDS, TB, and malaria. It helped change the dialogue that places that are under-resourced can actually provide really good care, and antiretroviral care is possible. And with that, it felt like an organization I could at least apply to. So the brief bit here, I was, the capital is in Harare, and I was in Bulawayo. So a little bit of the political infrastructure here. If you drew a diagonal line, you have 2 very different regions. The people here speak Shona. This is Mashona land, and the people here speak Indebele. And the Indebele are a different ethnic group. It is much more dry and arid here. The Botswana, the Kalahari Desert is right here and extends into this region, among the most arid places in the world. And they're culturally, the Indebele are very similar to the South African Zulu. And so it's a click language. And the Shona, it's more of a tropical, lush region there, where a lot of the produce is grown. And the reason all that is relevant is similar to the Nigeria story I just shared. Robert Mugabe, who was the dictator for 40 years, was from Harare and was Shona, really cut off a lot of the supplies to this region. And when HIV as an epidemic was rising up, Bulawayo, which was a city of 1 million people, so the 2nd largest city in the country, had essentially no consistent HIV care. And so MSF did see that as an epidemic. And so with a maternal HIV rate as high as 25% for women of childbearing age and to have no HIV care, they did consider that emergency. Now, by the time I got there, there was a power sharing. So the vice president was Indebele by the time I got there, and there was a large opening to other organizations. So Clinton AIDS Foundation came in, the Elizabeth Glaser Pediatric AIDS Foundation was there, UNICEF was there, and so we were closing our project. So I got to learn the transition piece, which is a whole nother interesting piece to be there. How do you learn? Going back to that question of clinical care when you're there, how do you learn about something you rarely ever see, if ever, when you're there? Is you read a lot in the evenings when you're there. You get guidebooks. There was, through Baylor, I think it's like a 130-page PDF book on HIV care that I still reference and still pull up sometimes. And that was my crash course in learning. For malnutrition, there was an 8-module course through, I think either through UNICEF or UNDP. And that was interesting was the price of it was linked to your IP address. So if you were in the US or Europe, it was like $1,000 course. If you're in a middle income country, it was 100, but if you were in a place like Zimbabwe, it was a free course. So I got to complete this 8-module course to become the director of our malnutrition unit. So I got to learn all the elements of kwashiorkor and how to treat it, and got to learn a lot about this little satchel that's in this child's hand here. So Plumpy Nut is the brand name, and that was developed by UNICEF with MSF support and a few other organizations, and it has changed the game for malnutrition care. Previously, kids had to be hospitalized for severe acute malnutrition and need an NG tube per feed. And this, along with other developments, have allowed them to develop something that is shelf stable, has all the macronutrients, all the micronutrients, and is palatable to the local community, and was able to dramatically increase the amount of kids who've been able to be treated. So one of the many things I learned while I was there. Of course, learning the politics about food and food aid. I did get to work closely with World Vision, who did a lot of the food support in Zimbabwe and the politics of food. So for example, one not so fun fact, the World Food Program, anybody want to guess on average how much of their budget is just to transport the food? I'm gonna throw a number out there. So it's about 40% in some places. And part of it is linked back to some contracts that are made with the US. For example, corn is flown out from Iowa to the middle of Africa, when there could be other produce, and you could develop things that are there that would be even more palatable and more locally sustainable and help the economy. And so understanding the politics of it was something that was also really eye-opening for me to understand these larger systems at place. I won't go too much into these stories, but I think one thing that was really amazing to me is just the personal stories I got to learn about not only the teens that I cared for, but even the counselors who came to work with us at MSF. So Sibonge was a VP of a bank in Harare, so a pretty high up executive in a country where really women didn't rise to that level that much. She was really seen as a model in her community there, and really everyone looked up to her. A really intelligent woman who was actually also a professor for the business school in Harare, and she saw her own nieces become orphans because of HIV, and really rededicated her life and said, you know, I'm going to give up all of this and just become a counselor and just to talk to the teens, because she felt she connected there. And so she was working with us as just a counselor for them. Another example here is Tlan Tlan. Tlan Tlan was a principal at a school, and he also saw that a lot of the children were becoming orphaned and were being cared by their gogos or their grandmothers. And he himself wanted to leave that work and come to MSF and help support the work that was there. So and this is transitioning from MSF, and as the year went on, we had less and less MSF staff there and more of the Ministry of Health. So this is the Ministry of Health nurse that we were supporting, and by the final month, I was no longer offering direct patient care and really in a supportive role and making sure the supply chains for the antiretrovirals were there, that the CD4 reagents wouldn't run out, that the teachings that were going on would still continue. Knowing that with 80% of the resources dropped, that it's not going to be the exact same standard of care, but being able to have those frank discussions of what's realistic and what's sustainable for the community. The other piece was to do decentralization. So instead of everyone having to come to this main center, and sometimes transportation costs would be the equivalent of 2 weeks salary for some of these folks who are coming from 2 hours out, how could we set up centers in different parts of the country? UNICEF built this resource center in our final year there so that the teens could have a place, and every teen who was starting antiretrovirals during their counseling would get paired up with a peer counselor. And among them, I'd say 60% had lost at least one parent to HIV, and about 30% were what we consider double orphans. So single orphan losing one parent, double orphan losing both. And just the tragedy of what feels really heavy on them and not wanting to take medicines or giving up on their lives, having these other teens with them was pretty amazing. I got to do a weekend retreat with them, and it was probably one of the funnest weekends that I got to have there. They also created song and local tradition. A lot of the Ndebele culture is oral tradition, so they pass on stories of their ancestors and stories of their times through song. And there's been a lot of songs about TB and other diseases that are old, but there wasn't anything about HIV. And so they actually helped write some new songs. So they're in circles, use percussion, use on their chest, their feet, and basically like an a cappella group. And it was moving, like put me to tears to be able to hear them do that and to try to move their country forward. The other inspirational group was the mothers. So PMTCT, the Prevention of Mother to Child Transmission, is something that completely changed the game for pediatric HIV. Sometimes as little as a single dose of AZT, one of the very first drugs, zidovine, that was found for HIV, can prevent transmission by as much as 90%, and antiretrovirals, a triple, can be as much as 99%. And of the mothers in our program, we had a 99% success rate that the babies did not have HIV. And in a country where there's still stigma against HIV, there's still misogyny, that moms can't go out and speak, that their husbands have to give them permission. These women are really courageous. They risk their husbands leaving them and cutting off supplies to them. And this mom here in the middle, even more so. She had a child with albinism, and unfortunately, there's a lot of misconceptions and a lot of rumors around children with albinism that there's witchcraft or that they're possessed. And she would take this child with her everywhere to both demystify both of those things, that HIV medicines can prevent it passing on to a child, and her child is a healthy human being who deserves all the rights. So they were inspirations to be able to work with.
Yousef,
yeah, go ahead, Chris.
Were the moms breastfeeding?
Yes, the ones who, yes, they were breastfeeding when they, but usually they were also encouraged if they were breastfeeding to continue on their medications. But there were some who didn't, and they were informed with what the risks were. Yeah. Another great thing in the final year, we did a lot of training. So I would do 5-day trainings and we'd have up to 40 people, and it was everyone from pharmacists to nurse directors to teachers to other community leaders. And the 5 days covered everything from at the molecular level, what is a nucleoside reverse transcriptase inhibitor, all the way up to when the teen loses a friend or loses a family member and they want to give up on life and give up taking medications, how do you counsel them to continue to take the antiretrovirals so they don't become resistant to that particular strain? And so covering the whole gamut, it was a pretty rewarding thing to get to set up and to do. And we use local Ministry of Health curriculum, so we could partner with them and be able to contribute the budget and created working groups so that people could connect together even after the meetings were over. Getting to go with my colleagues to other meetings. These were, this is one of the fun things in the evening. So Nuria was a family medicine physician from Portugal, and she was in one of the more rural sites. I was in the big city in Bulawayo. And Ahmed was a Sudanese internist, and he was working at the border with South Africa. So a lot of border medicine work that was happening there. And primarily there was a lot of the HIV incidents were higher level and through prostitution and through drug use that was being smuggled either both ways across the country. And getting to work with them and learn from them and share was a big part of the social life there. The one piece I reflect on here is, you know, we have a team building games, so a 3-legged race is what's going on here for me and my fellow Doctors Without Borders staff. I got to acknowledge my own internalized racism and my own internalized prejudices I had around different countries or different people. And it also gave me a perspective coming back to the US, seeing the effects of slavery on the African Americans here. When you live in a place when it's Africans and everyone is Black, there is prejudices that exist maybe across cultures or across wealth, but actually seeing a model where it doesn't have to be just based on skin color. Also for myself, getting to start being able to see the nuances of everyone there. Everyone at the beginning kind of sounded the same or seemed the same. And I'd say the analogy is like going from the dark, like stepping out into the light, stepping out into the sunshine. Your eyes take a while to need to adjust. And it took me a while to be able to start learning about them. But by the end of the year, I probably know each of these people on a deeper level than any other workplace I've been, because you spend your whole days with them, your evenings, depending on where you live, you get close. So I got to know people here really well, and it helped inform my journey that I can speak out around equity issues in a way that I feel more confident about, and got to learn them with the different experiences I had. I won't go over the cases, I'm realizing with time, but if you are working with me on a night shift, you'll get to learn a little bit more about these. So why did I decide at the end of the year, if it was the most rewarding year of my life and I love Doctors Without Borders, why am I still not doing Doctors Without Borders, and why am I still not international? And this is sort of the elephant in the room. There's this thing called student debt some of us have. So between my med school loans and my wife's law school loans, we needed to find something. Thankfully, there are places in the world where you can go and actually get paid a decent salary. And as I alluded to, Chris was in Saipan, and I found out it's a US protectorate, it's a Commonwealth. And so they have Medicaid. And so as a result of that, they can pay a decent salary, probably about 2/3 of what the salary would be in the US. But with their tax bracket, not having federal tax, the highest tax bracket is about 9%, ends up being a fairly good situation. So I said, well, sign me up, I'm coming out. And my wife was at The Hague. This is in Holland. We're in Amsterdam here. She's a human rights attorney. So she was doing war crime prosecution, and she was on the case of Charles Taylor, who was a former dictator who what was that?
Liberia.
Yep, exactly. So yeah, between there was work in, I think, Liberia and Sierra Leone were some of the other atrocities that happened. So child soldiers, blood diamonds, all that work. And she got to be there for the closing argument. So got to be part of that case. And he is the first ever former head of state to actually be successfully prosecuted for war crimes. So we all joked she peaked early, like really what else in life can you do after putting away a war criminal who was a former head of state? But she was also looking for something. And so she and I decided Saipan seemed like a worthwhile place to at least try for 3 months. And so we went to this beautiful tropical beaches, and this isn't actually Saipan. It's one of the neighboring islands that we got to travel to. I'll skip this one for now. Sorry, actually, some of the slides repeat. This is Saipan. So it is a tropical paradise. So it is, this is their own slide, which I think is a beautiful one. If you do want to work in a small rural island, sandy beaches, you're welcome out there. And these are all actual real pictures, no filters back then, no Instagram filter. Where is it located? It's about halfway between Japan and New Zealand, 1 hour time zone ahead of Japan. So it's part of the chain of islands. The southernmost one is the one probably most people have heard of before, Guam. Guam is a territory, and the rest of the 13 islands are a commonwealth. So Puerto Rico is a commonwealth most people have heard of. There is a second commonwealth for the United States. Now you know it. So you can answer that at a trivia night maybe sometime. The other commonwealth is the Northern Mariana Islands. And there were 3 main islands that had decent habitation. By decent habitation meaning more than 3 families. There were Rota, Tinian, and where we were at Saipan. So we were actually a referral center for the other 2 smaller places. But then being that we have no subspecialists there, we had to transfer out patients and had to go on flights with our patients as necessary. It is very small, hence the region called Micronesia, that part of the island. All 14 islands combined were 184 square miles. And that's about the size of the county that I'm in right now, County of San Mateo, just to give a sense. The local ethnic group, the largest one is the Chamorro. Carolinians were from the even more remote islands to the south. And just to show that prejudice and racism exist everywhere, the Chamorro were people had moved into agriculture earlier and so had a little bit more wealth, whereas the Carolinians were still more of the fishermen, and they were darker skinned because they spent time out, fishing on the small atolls. And so there was a prejudice that Chamorros were sort of above the Carolinians, but that even had been changing over the couple of generations. And so when Chamorros do marry Carolinians, they're now called Chamolinians, which I think is a pretty cool name. It is a major destination. So think of like all the Dominican Republic, Jamaica, the equivalent of Caribbean islands for Northeasters. This would be the island for the Japanese, the Korean, and the Chinese. So we had a lot of tourists come there. A lot of birth tourism was happening. By the time I got there, the number of Chinese national births now had exceeded locals' births, and that continued to rise. And so that was leading to a whole set of new challenges and complexities there. My wife and I were probably in the best shape of our lives while we lived there. We got to bike, kayak, scuba dive, all types of things all day long. And because internet was slow, you're not just at home streaming, you're out and about all the time. They are in the Guinness Book of World Records for most consistent temperature. So the average daily temperature over the course of 7 years only varied 8 degrees. So it was consistently between 78 and 85 degrees. The average within the day it might change, but that's the average daily temperature. So a pretty amazing paradise to be in. And I, again, you'll have to be on rotation with me to do the cases because I know we're now at time. So I will talk, you'll get to preview these later if you ever get to rotate with me. And sorry, I will jump forward. So I want to thank all the parents and children of CNMI, all those who trained me here when I was a resident, my MSF colleagues, a couple of people who played a big role in bringing me to UCSF when I transferred up. Monica for giving the talk about Saipan that played a role for me, and then Chris for helping play on the journey for me to know about Saipan. This was my final day of continuity clinic. Some of you might know some familiar faces that are here. Naomi Bardak, I still think is around, Josie, still involved, and happy to answer questions. Thanks, everybody.
Thank you so much. I will open it up to anyone if they have questions, and thank you for leaving time for questions. Appreciate that. And then also just to say that Tiffany has dropped a link in the chat for our evaluation form. It's very quick, 3 to 4 questions. We do really appreciate your thoughts and feedback. So if you could take a minute to do that, and then leave the floor open for questions.
Yeah, and maybe if I can add, if everyone can just put their name and sorry, their name is already there, but if you can put your affiliation in the chat, that might be helpful for Yousef to get a sense of who's here. And you can see where the
Thank you.
conversation goes.
Yeah, appreciate that.
So I'm happy to start with a question about where you are now and how you think that has like how you think your journey has influenced your perspective or your work as the county medical officer now.
Yeah, it's a great question. So being able to handle situations where you don't have a lot of experience in, being able to handle it when resources are suddenly gone or very minimal resources are around you, being able to handle interpersonal dynamics in a culture that you know very little about, just makes all the problems that you deal with here that much easier to be able to handle. Not that problems back domestically aren't challenging and don't have their own level of complexity, but the confidence you build up, being able to handle those. And going abroad, even though it's really your clinical skill set that might be unique or different, people look to you as a leader in general. So you quickly, as a US trained physician, will be elevated and given opportunities to enter into leadership roles. And I took those opportunities. So I didn't get to share, but I became chair of our Department of Pediatrics in Saipan, which really means overseeing 4 providers, but really being that clinical go-to for the chief of staff there, for the hospital, understanding recruitment, being able to get the HR pieces, in addition to creating the schedule and all the other elements. It also, for me, made me realize you do this work because you want to see systems level change. And the way I describe my role now as a chief medical officer, in addition to having a primary care, when I have my own panel of patients, my panel is all the leaders of my organization. And so just as your panel of patients, you'll have a few who might have acute needs or chronic or going through a crisis that you need to spend more time with them and see them more frequently. Literally the call right before and message I'm getting now, we have a bit of a crisis of a transfer. We don't have as many oral surgeons around right now. We have a gap in our urology. And so helping my leaders understand how they problem solve and helping them be there for them and to think through, okay, do we need to up the salaries? Do we need to figure out how people can cross cover? Do we need to create a partnership with our local hospitals here? So I'll be reaching out to the chief medical officer at Stanford and at Sequoia probably in the next day or two about some issues. Those same level of being able to think outside the box and to problem solve in a way that isn't within the box normally and stretching yourself too. So as Chris can also attest to, the things that you have to do when you're abroad and the range of what's expected of you make you clinically more competent than anyone could ever be here. Not to be arrogant, but the things Chris and I could feel comfortable with and to handle as a generalist without doing fellowship would be probably more than some people in certain subspecialties would even after fellowship training, just as a function of not having other attendings that are there, not feeling that internal restriction of what's possible, but really thinking for yourself, what do I know? What do I find online? What do I find in a book? And knowing also in that same way that you can constantly change. That I did in those 3 years. I was a NICU hospitalist, I was a HIV consultant, and then I was a generalist in Saipan. It gives you that sense of confidence that, yeah, you can do anything if you really just allow yourself to feel open to learning and knowing that at the beginning you'll be super nervous. And as I share with the interns who rotate with me, I remember as an intern just having like baseline tachycardia, just always feeling kind of like nervous and like, am I going to F this up? Is this the right way to do it? Like, who am I supposed to call? And being comfortable that that is part of the learning opportunity and learning growth, that whenever you step into a new job, I didn't choose to be the chief medical officer for a county on my own. The previous person retired about 4 months into the pandemic. Like a lot of people are like, yep, I'm kind of done. I've had my time. And it was 3 rungs up the ladder. So it was my boss's role, but neither the people beneath her nor anyone else laterally felt like they wanted to step into it. And a few people reached out to me like, you have the patience, you have the background of dealing with wild, ridiculous things with resource limited settings without knowing what's going to happen ahead of us. I think you would be great. So I tried it out as an interim, and I'm the first pediatrician to be a county chief medical officer that I know of here in the Bay. And it just being that first to do anything, there's always a little bit of anxiety that adds a layer to it, in addition to being like a fairly new person in the role. But yeah, I got support. I like everything else that I've done. Ask questions when you don't know. Don't pretend if you don't know what's going on. And it definitely has been a really wonderful journey. Maybe I'll allow Chris, if you want to add to that answer as well, given that you've also done a lot of clinical work and have also stepped into some leadership roles yourself.
Yeah, happy to talk. I did want to talk a little bit about having a global health career with a partner. Would that be okay to
Let's do it?
talk?
Yeah.
Okay. So my wife is in public health, and whenever we were thinking about a place to go, we always made a joint decision about how we could both be impactful. And there were some instances where I deprioritized what I would be doing, and she was able to feel very useful and impactful. And I think that's really important to make decisions together. And whether it was Haiti or Nepal or East Timor or Congo, we always made sure that we had both had something that we could do together. And it was, and I think that going together and having those really intense emotional experiences together allowed us to grow as a couple and grow as a family. And I think it would have been very challenging to do those on our own. So I think it's definitely doable to do as a couple and as a family. And we spent 2 years in Haiti together with our kids, and we're able to see the kids grow. So I think it's even doable as with kids. So I encourage people to think about how to best do that with a partner and kids, but definitely is something that you can do. Yousef, I really wanted to congratulate you on a great talk, but your career trajectory has been amazing. To be at your stage in your career as a CMO is almost unheard of. So you're doing amazing work.
Thank you. Thank you. You've shaped a big part of it. What other questions do people have?
Yousef,
go ahead, Chris. Sorry.
Yeah, I'd love to. One thing I really struggled with is there is quite a bit of morbidity, mortality, more so that we see in Yusan, Zimbabwe. And I really struggled with mental anguish of not being able to do as much as I could for my patients in Congo or in Zimbabwe as I could here. How did you deal with that, both immediate period and now?
Yeah. So I do talk about this. So a preview for any of the residents who will listen to my talk. I give a talk in Saipan about a baby who died, who I had to talk the family through withdrawal of care. I think two different things. One, I would say my faith played a role, like my deep understanding and appreciation for purpose in life, and that, you know, for various reasons, God has made us so that some of our journeys end after our first few hours of life, and some persist, and that there's grander pictures. So I think a little bit of that philosophy piece. I think the other piece for myself internally is that those transition moments and the end of life care, that how you deal with those things, that's what's in your control, will forever shape how those families remember that moment. And so when you give them some level of autonomy of decision making, and so I'm also grateful that I had really great clinical thanatologists in med school. So anyone know what thanatology is? And I think maybe if you've been on a talk with me. So now it's a little bit more known because Thanos, yes, as in Thanos from Marvel world universe, is the thanatology is the study of death and dying. And so he destroyed half the universe, right, in the movies. And so we had this really great ethics clinician who really allowed us to talk about death and dying and what our own personal beliefs are, what our cultural beliefs are, and realize that no matter how much we move to artificial intelligence and protocols and guidelines, nothing will replace those end of life discussions that you have with families. And so I really got to practice those, learn those, see good models of those, and spend some time with Child Life and PICU too, like knowing I might, be able to, this is something I might want to do, and really be thoughtful about how to have that. And so what I landed on, and the reason I share that case is one of the ones that was most rewarding for me, is it was a twin transfusion, and so the babies were born with one with a hemoglobin of 3 and the other one with a hemoglobin of 19, and I knew that second baby was not going to do well, and so started prepping the family. And as we knew we were approaching withdrawal of care, finding what those sweet spot of decisions they could make, saying, I'm going to withdraw care today. Do you want it now with just the two of you here, or do you want to wait for your family to be here? Do you want to be there for the extubation, or do you want to just be in the room where you gave delivery and I can bring the baby there? Would you like me to stay in the room the whole time, or would you like me to step out? So finding really what those pieces are, that there's some ability of control of what feels like a situation that is completely out of their control, and allowing myself to realize like that's all I could do in those moments. There's still anguish about those. I still sometimes cry about the kids who I lost, the kids who died. And it's also the highs and lows too, right? The seeing it with HIV, seeing the Lazarus effect, seeing those kids who were completely emaciated look like they, from like the biblical story of like coming back to life when you got to care for them. And that sense of like balancing it with ourselves, right? Like Chris, when we're out there, here in San Francisco, there's 400 pediatricians, right? If you include all the residents and everyone else. If you don't show up to work that day, there's probably somebody else who can show up. But in these places where you work, that is not the case. You might be literally the only person who can do the care that is needed that day, or maybe one other person. And just that sense of purpose as well, I think really buoyed me through those times.
Wise words, very much appreciate that. Seeing a question from Molly in the chat. Love to hear tips or ideas on how to become involved if your partner can't travel with you.
Great question. So we had a really tough decision at the beginning of our marriage. So we're that crazy couple that as we were having our wedding vows, we're already planting the seeds for us to be apart for most of the first year of our marriage. And I knew that there wasn't a lot of underserved work for me in Holland, right? I wasn't going to be able to go to The Hague and practice there, but that was going to be really important for her to spend the 6 months for her career and where she wanted to go to work at the International Criminal Court. That was an amazing opportunity for her. And I also knew Doctors Without Borders very rarely allows you to have a partner in the field with you for your first mission. And so we realized if one person just followed or just traveled, we would potentially resent the other person for having given up our career, and or it just wasn't going to be possible. So just understanding that level of sacrifice. It also maybe the other piece, like we did long distance for a while. Like she was in law school at Case Western for her first couple of years, and I was, in residency here in San Francisco in the NICU hospital. So we kind of already were used to that. But having those discussions, like this is really hard. This is really challenging. We're starting to develop close friendships and deep bonds with other people that you don't know, and for that extended period of time. And as Chris was talking about, going through really emotionally intense experiences with other people bonds you with other people. And so there is that fear that you might start feeling attracted to or closer to or confide in someone else. And so the whole other topic of like how to deal with what people feel of like maybe emotional closeness, like where people's comfort zones are for that with your partner or without if you can't be in touch with them. But for us, it was understanding that short term, that first year of marriage, we only were together for 9 months. 3 months of the 12 months that we were actually together, and I included vacation, included other pieces. But knowing after that we would commit whenever possible to actually be in the same place, and we were. There was another 3-month lead time, going back to Chris saying, when basically the cards were in her plate for Saipan when we ended our time there, and she felt she was ready to leave earlier than I was, and so she left back, and wherever she wanted to find a job, I was going to come afterwards. And so she found one in LA. We met in LA, and that's where her family's in Irvine. And so she went first, interviewed, found a job. And once she found a job and found a place, then I ended my time and joined her and found a piece there. So I think maybe hopefully that's helpful, but happy to hear if there's a follow-up. And I know we're starting to get over time, but I'm happy to stay on for a few more minutes.
I did a stint in Liberia just before I got married with my wife, and I made sure that we touch base if we could daily or other times, just so I could share those intense experiences with her so that we could continue to stay connected.
All right. Well, thank you both, I'll say, Yousef and Chris, for I would say really opening up, sharing candid personal stories of your reflections on your journey so far. And as Chris has just mentioned to Yousef, we look forward to seeing where your journeys go. So congratulations on your many successes and the great work you're doing. I imagine, would it be all right if folks get in touch with you, Yousef, if they have any questions or follow-up?
Absolutely. That's why I'm here. And I say that to all the residents I meet too. I didn't have someone who had this type of journey that we got to know ahead of time. And so you can find me on the UCSF list. Just look up my name. I'm happy to have a conversation with anybody. I just talked with Jean Jr. A couple of weeks ago she's about to apply for MSF herself after finishing her EM fellowship. So I stay in touch with folks even after they leave too. So thank you all, and you all are doing great work, and you will get to whatever your journey is. I assure you, you will, and what's right for you, and happy to help you along the way.
Great words to close on. Thank you again.
Bye.
Thank you.